Live from the North Carolina Museum of Natural Sciences in beautiful downtown Raleigh, it's the Science Cafe with your host, Chris Smith.
All right, everybody, let's get the Science Cafe started. Good evening, everybody. Welcome to the Science Cafe here at the North Carolina Museum of Natural Sciences. Look at all these fabulous people here with us tonight. This is a fantastic crowd. I guess tonight's topic relates, right? No matter who you are, where you're at, tonight's topic is one that you want to know a little bit something about. Well, welcome to the show, everybody. My name is Chris. I'm curator for the Daily Planet Theater here at the museum, and I'm your host every Thursday night for the Science Cafe. So, anybody, this is your first Science Cafe, and welcome. Welcome. I'm so glad you all came out. Come back again. We're here every Thursday night at 7 o'clock, and Katie is telling me to tell you to put your email down so that we can send you an email, let you know what topics are coming up every month. We'll send you one message. You'll know what the month's topics are going to be so that you can come back and visit us again. We have a lot of fun here at the Science Cafe, don't we? Yeah. Okay, good. I see they're trained. They did a good job. Tonight's topic, you know, I had this really great introduction, and I forgot it. This is, and tonight's guest tells me it's something about approaching the age of 33, that you forget your introductions. Now, tonight, so we're just going to get right to it. I want you to meet tonight's special guest. It's Dr. Lynn Kakos. She's a clinical neuropsychologist at WakeMed Health. Put your hands together and welcome Dr. Kakos to the stage.
All right. Thank you. Can you guys hear me okay? All right. I have to tell you, Chris, that some of your thinking skills do start to decline in your 30s, but we'll get to that in a little bit. So, thanks for having me. I think this is such a neat group that I wasn't aware of until I was asked to speak here. So, kudos to all of you for braving the cold and coming out and hopefully learning something. No pressure for me. I got to make it worth your while for getting out here. But my name is Dr. Kakos. I'm a clinical neuropsychologist at WakeMed Health and Hospitals, and I'll tell you what that means. Does anyone know what neuropsychology is, or has anyone heard of that before? I'm probably not that kind of doctor, but we'll get to that in just a second. But before we get started, of course, I have to give my disclosures. I have no financial relationships with commercial interests that pertain to the content presented in this program. All right. So moving right along, what is clinical neuropsychology? So clinical neuropsychology is described as the study of brain behavior relationships. And basically what that means is we take a look at how changes in the brain can manifest into changes in behavior, and we're particularly interested in changes in thinking skills or cognitive functioning. And so we are licensed clinical psychologists who go through specialized training in neuropsychology, which involves an internship and also 2-year postdoctoral fellowship in neuropsychology. So what neuropsychology involves, typically our appointments consist of a clinical interview with a patient and also hopefully family member or some type of collateral report to gather information about why they're there. And then we do a thorough evaluation of thinking skills that's comprised of standardized tests that we administer, and then we utilize normative data that we have, so based on individuals' age, gender, ethnicity, educational attainment, really to get a sense of how that individual is performing in comparison to their healthy peers. We're really looking for patterns of performance, what we call cognitive profile, to see if the way that individual is performing is consistent with a known neurological condition. And then we provide feedback to family and the patient and give some treatment recommendations for those individuals and also for the referring provider. So that's just a little overview of what we do. Clear as mud now, right? All right. But tonight I'm going to talk to you a little bit about healthy cognitive aging and what that looks like, and then how we can start to differentiate between normal or healthy cognitive aging and abnormal aging, or what some people call dementia. So one definition that I found for healthy cognitive aging that I like describes it as a fade out of memory and intellect that medical science considers too gentle for treatment. So what I like about that definition is it sets up an appropriate expectation that there will be decline, unfortunately, for all of us. We're all in the same boat in this room, that our thinking skills will decline as we get older. So it's good for us to know that, but also to know that normal aging or normal decline really shouldn't have an impact on your daily functioning, okay? So being able to kind of function appropriately, manage medications, that kind of thing. So we'll talk a little bit about what the brain does as it ages. And again, this is within a normal, healthy individual. We can start to see shrinkage in the brain, so often called atrophy. So areas of the brain will start to get smaller, and particularly this is found within the prefrontal cortex and also within the hippocampus. And it's important to know that because both of these areas are really important for cognitive skills such as learning and memory, and also what we call executive functioning, so higher level things like problem solving and planning. We can also start to see slow communications between brain neurons, reduced blood flow as our vessels start to narrow as we get older. We can see development of what are called plaques and tangles, and those are correlated, those mechanisms are correlated with Alzheimer's disease, but actually to some degree it's normal as we age. It kind of reaches a tipping point where it becomes an abnormal process. And then finally, we can see, just like everywhere in our bodies as we get older, we can see inflammation within the brain as well. And this, for those of you who have access to a screen, you guys can see these screens, yeah. This is just a nice visual depiction of a normal 28-year-old brain and then a normal 78-year-old brain. So with just a healthy individual who's declining, or who's aging appropriately or aging healthily, you can start to see those dark areas in the center. Those are the ventricles. They're becoming more enlarged because of that shrinkage or that atrophy we talked about earlier. And you can start to see some more of the darkening around the brain as well, between the brain and the skull, because of atrophy too. So again, normal. So as we get into talking about cognitive functioning or thinking skills specifically, there are kind of two principles or cognitive principles that I think are important to establish first. One being fluid intelligence and the other crystallized. So when we talk about fluid intelligence, it really refers to someone's ability to problem solve, reason, and these are tasks that are kind of less familiar, not overlearned things. And so fluid intelligence, which consists of processing speed, problem solving, even memory, those areas start to decline with age in a normal, healthy individual. And even some of them start to decline in our mid-30s, if you can believe that. I can believe that. So fluid intelligence, again, starts to decline as we age, and that's normal and that's appropriate. Crystallized intelligence is something that is more comprised of overlearned things. This includes things like vocabulary and just general knowledge. And the good thing about crystallized intelligence is it remains stable as we age or even improves. And you can kind of think about yourself. I'm sure my vocabulary is better than it was in my 20s, and hopefully will continue to grow that way as well. Okay, so we'll talk about our 6 cognitive domains. So when we think about thinking skills, we can break that down into 6 domains. So, and we'll do a little bit of a deeper dive into each of these, but Those 6 domains include processing speed, so how quickly we're able to think and take in information, executive functioning. I like to describe this. You can think of the responsibilities of an executive of a company, so kind of higher level organizational abilities, problem solving, thinking flexibly. Attention and your ability to concentrate is another domain. Our language abilities is another domain. Visuospatial functioning, so kind of seeing the world accurately, being able to judge distances and things like that. And then finally, learning and memory, which we all think about when we think about aging, don't we? So the first cognitive domain we'll talk about is processing speed. And as I said, that's really your ability to think quickly, do cognitive activities quickly, and to some degree that involves a motor response or a quick motor response as well. So aspects, or pretty much all aspects of processing speed do decline in a healthy individual as we get older. So I made some little tables there, and in the left column we have those things that decline, the right column those that remain stable. Some of them are more balanced than processing speed, but as you can see, there's nothing about processing speed, unfortunately, that remains stable as we get older. And I think another important thing to think about with respect to processing speed is it's really challenging to kind of take that element out of our testing of other cognitive abilities. So for example, if we're trying to assess someone's attention, well, how quickly they're able to process that information has something to do with the fact of whether or not they're going to, retain that in their short-term memory. So processing speed is one that really impacts a lot of our thinking skills and can impact a lot of our functional abilities too. Can anybody think of something that we do on a regular basis that involves processing speed? Exactly. Yep, driving. Yeah, so, just important to kind of keep in mind that to some degree, these things are, normal as they decline, but there does reach a point where those things can negatively impact our daily functioning, and we'll talk more about that here in just a little bit. So already kind of set the stage for executive functioning, but again, this includes those higher level things, our capacities, for problem solving, thinking flexibly, being able to think through or abstract reason through novel situations. And when it comes to executive functioning, I was like, where's my table? So this one's a little more balanced than the processing speed, as you can see. So things such as concept formation or coming up with new ideas, thinking abstractly or reasoning through things, being able to think flexibly, being able to inhibit unwanted responses, and even speeded executive functioning tasks can decline as we get older. But the good news is some things remain stable, so your ability to verbally reason and come up with similarities, that's one test that we'll use at times to look at executive functioning. Can you tell me how this and this are the same or similar? So kind of an abstract verbal task. Also your ability to describe the meaning of proverbs and reason with familiar material appear to remain pretty stable in a healthy individual as we get older. Okay. Our next cognitive domain is attention, or as I said before, your ability to concentrate and kind of sustain your attention. And so again, this is one of those unbalanced ones where we tend to see pretty typical decline as we get older. And maybe that's something you've even noticed in yourself, but slight declines are noticed in your simple auditory attention. So one test that we may give to assess this might be to ask someone to recall a short string of numbers and repeat it back to us. We might see a subtle decline in just your kind of simple auditory attention, but we'll see greater declines in more complex attention tasks and what we call working memory. And working memory is really your ability to kind of hold on to information in your short-term memory and manipulate it in some way and give it back to us. So instead of just a string of numbers, you might actually be asked to rearrange them in some way and spit them back to us. So that's something where we'll see more significant decline with age. In terms of language abilities, as I said before, this is comprised of some crystallized abilities, so vocabulary, for example, but we also have some fluid abilities in there too, meaning confrontation naming and verbal fluency. So being able to come up with words for different objects. How many people have that tip of the tongue phenomenon? All the time, right? And to some degree, that's really, really normal as we age. But, you know, there does reach a tipping point when it starts to impact your ability to communicate appropriately, where that may be more abnormal. Another area of language that starts to decline as we get older is what's called verbal fluency, or your ability to come up with words within different categories. Okay. And then the next domain to discuss is kind of evenly split in terms of what remains stable and what declines. So your visuospatial abilities, like I said, your ability to see things accurately and judge distances. Constructional abilities, like being able to accurately copy a figure, can decline with age, whereas your visuospatial abilities, being able to kind of judge distances and have accuracy in that, remains pretty stable over time. And then lastly, the big one that people are really concerned about when we talk about aging is memory abilities. And so this one is actually, and maybe a surprise to you, a little bit split in terms of what remains stable and what declines with age. So delayed free recall, your ability to kind of spontaneously come up with information that you hopefully previously learned. Source memory, so knowing where you heard that information, like my friend told me, or I saw it on the news. Your perspective memory, or your ability to remember actions that you intended to do in the future, like I'm gonna go to the kitchen and grab this from the fridge. Yeah, we hear that one a lot. And also the rate of learning new information. And again, what thinking or what cognitive domain might impact that we've already talked about? The rate of learning new information. Your processing speed, exactly. So these things start to decline in normal, healthy, aging adults, whereas we'll see some stability in terms of recognition memory. So you may have a hard time coming up with that person's name, but if somebody gives you a hint or cue, you're like, oh, that's right. Your temporal order memory remains stable, so your memory for the correct time or sequence of past events. And then your procedural memory, your memory for how to do things that are kind of overlearned over time, like riding a bike. Those all remain stable as we get older. All right, so this kind of breaks it down for us. When we start to see changes in thinking skills as someone gets older, often individuals come to us because they're concerned that maybe something pathological or some type of pathological aging or dementia process is taking place. So I kind of broke it down in terms of what's normal and what might serve as some red flags or concerning symptoms that someone might have. So for example, memory lapses without any type of functional impairment. So someone, may be forgetful at times, but still able to do some of those higher level daily functional tasks like managing finances, remembering to pay bills, remembering to take medications, driving without incident, being able to recall or recognize instances of forgetfulness. So if we have someone who comes to us and they have a long list of all the things that they forget, that's less concerning than someone who might have no insight into their difficulties. Which is why we have family members come along too, because we can oftentimes get a pretty different perspective. What's normal is maybe pausing to remember directions. What's not normal is becoming disoriented, particularly in familiar places. What's normal is occasional difficulties finding words, but like we said before, if it's starting to impact your ability to communicate effectively, that might reach the point where we would be concerned that that's an abnormal aging process. And then also what's normal is having stable decision making. whereas poor judgment and poor decision making would certainly be cause for potential concern. Okay. Does anybody have questions so far? Okay. I wish I had jokes like Chris, but I don't. So, okay. So you don't remember what questions you have? That's a good one. That's a good one. I like that. So when we start to see changes in thinking skills that are above and beyond what's normal, so remember what's normal, the left side of the column or the table there, we consider, a couple different diagnoses. The first being mild cognitive impairment, or there's a new term for it, mild neurocognitive disorder. And this really just encompasses an individual who is having problems or changes in thinking skills above and beyond what we would expect just for their age, educational background, gender, ethnicity, but it's not to the point where there's any type of functional impairment associated with it. So, they're forgetful, or they may have to write things down more frequently, but they're still, functioning at a pretty high level, consistent with what they were doing before. So they may need more strategies, but those strategies are working for them. Whereas when we start to see changes in thinking skills above and beyond normal aging that also then interfere with daily functional status, that's when we consider a diagnosis of dementia. So it basically means you're having cognitive decline that's more advanced for your age than we would expect, and now you're having a hard time kind of holding it together in your daily life, and maybe it's more challenging for you to remember your appointments, get to where you need to be, manage medications, cook, those kinds of things. So I think there's a misnomer about dementia, and oftentimes people think that dementia and Alzheimer's disease are two separate things. But actually, dementia is an umbrella term. There are several different types, or lots of different types of dementia, and Alzheimer's disease is actually the #1 type of dementia. And that encompasses, we think, about 50 to 75% of dementia cases. Second most common is vascular dementia. You can think of what's good for your heart is good for your brain, because your heart's what's pumping blood, which is carrying oxygen and nutrients to your whole body, including your brain. And so vascular conditions like high blood pressure, high cholesterol, even diabetes over time can negatively impact your brain's functioning. And over time, we can start to see functional impairment as a result of that. So vascular dementia is the #2 most common dementia. There's also dementia associated with Lewy body disease and frontotemporal dementia. And these are just the top 4. There are quite a few other types of dementia as well. This is just an example of a normal, on the left, normal older adult brain, and then you can see a patient who has Alzheimer's disease on the right there. And we can't diagnose Alzheimer's disease based on, neuroimaging findings at this point. But I think that's pretty notable if you can see how dark the ventricles are and how enlarged they are in the center of the brain. And also you see quite a bit of darkness surrounding the brain as well. There's much less brain mass on the right as opposed to the left. Okay. Any questions so far? You're all very, yeah. Are you? Oh. He's bringing you a mic, so yeah.
Wave at me.
Yeah, right here.
Oh my gosh.
Yeah, a friend of mine is having a tap put into his spinal fluid to drain some of the fluid from the brain area, and I'm wondering whether some of the enlarged ventricle is due to that.
In Alzheimer's disease, you mean, or?
Yeah, in these pictures, or is that corrected for pressure?
It sounds like what you're describing is a hydrocephalus situation, and those are cases where they would place a shunt to release that fluid. So in Alzheimer's disease, it's not that there's too much fluid, it's just that the brain itself is atrophying, so there's more space in the center.
Yeah, and I guess the question I'm asking is, you can tell the difference, is that right?
There's a difference, yeah. Mm-hmm.
And what's the difference?
So in hydrocephalus, what you're describing, there's cerebrospinal fluid that's causing the enlarged ventricles. In Alzheimer's disease, it's because of atrophy.
Yeah, I guess I'm not trying to be a pain in the neck, but
Yeah.
from this picture, how can you tell the difference from the picture?
I can't tell the difference. I don't know if radiologists can tell the difference,
Okay.
to be honest with you.
Thank you.
But the presentation would be much different. So in hydrocephalus,
I understand that, yeah.
what's that?
Thank you.
Is that it?
Yep.
Okay. All right. Did somebody else have a question?
Can you observe these differences in a patient, or are these only visible in a section of a brain?
So that's a good question. So what our testing comprises of, so us, neuropsychologists, in terms of what we can observe. So we take into consideration a lot of factors, one being someone's what we call premorbid intellectual functioning. So we assess, or we kind of estimate where this person likely was in their cognitive prime, so to speak. And so we kind of not only compare them to their healthy peers, but also to their, ideal self, so to speak. And so for some individuals, they may have enlarged ventricles and, brain atrophy like that, but they may be functioning at a lot higher level if they start out at a much higher level, if that makes sense. So the research suggests that there's something called cognitive reserve. So folks who are brighter individuals, who have a higher IQ, have a higher academic achievement or attainment, typically have more cognitive reserve. So they may have ventricles that look like that, but they have a lot of cognitive resources that can make up for that. So looking at imaging doesn't tell you how they will perform on our testing. Does that answer your question, or does that make sense? Yeah. So that's why sometimes it can be helpful for us to take a look, because, someone's spouse may notice changes in thinking skills, but, it's not evident, just brief interaction that, physicians may have with that individual. But we can kind of take a look and see, well, this person was superior to begin with, and now a lot of these skills are kind of in the low average range. That would be a pretty big decline that we wouldn't expect. So they may not even have the functional impairment, but we're seeing a pretty significant decline that wouldn't be accounted for just by normal aging alone. Does that make sense? Does that answer your question? Okay. All right. So the good news, there's some good news, guys. So there was a pretty groundbreaking study by the MacArthur Foundation, and this study found that 30% of physical aging is likely due to genetics, while 70% is due to just lifestyle choices that we make on a daily basis. And in terms of our thinking skills and our cognitive aging, 50% is due to genetics and 50% is due to our lifestyle choices. So can you think of something that I already talked a little bit about that may have something to do with that? Like, what kind of lifestyle choices could we be making to positively or negatively impact our thinking? Yeah. Exactly. So we'll talk a little bit about that and some other things we can do. Because I don't just like to be doom and gloom. There's stuff we can do, so that's good. But first and foremost, talking about just kind of optimizing your memory, there's a lot of research that shows that just stress and just depression alone can negatively impact our thinking skills. So doing the best you can to kind of improve your mood, however that looks for you, reducing stress. Also making sure that you're reducing distractions, because if you're unable to pay attention to information, it's really hard to learn that. And if you're not learning it, it's hard to encode that and remember that later. For some individuals, visualizing information can be helpful to optimize memory. Making associations, again, providing yourself with some of that recognition or those cues can be helpful. Really staying organized, utilizing routines, so that you're less reliant on your memory in the moment if you're more organized. So having, a specific place for your important items at home, a specific place where you keep the calendar and it's one calendar and everything goes on that one calendar. The more organized you are, the less you have to rely on your memory. And also really trying to plan ahead can be important too. So there's a lot of research in addition to that shows that throughout our lifespan, it's really important to maintain a certain level of cognitive, social, and physical activity and engagement. So again, kudos to you guys for coming out tonight, because you're checking that top box and probably that second box too of being cognitively engaged while also being socially, active. But, when we're retired, we have to be more proactive about that and make sure that we're checking those boxes, because all of those things can help keep those neural connections strong as we get older. And we kind of already talked about this one a little bit, but, and you had mentioned vascular health too, but really trying to optimize our physical health, our heart health, is super important for our thinking skills and our brain health as we get older. We're recommended at this point to eat a Mediterranean diet, getting appropriate aerobic and resistance exercise and training, limiting your alcohol intake as you get older. We don't metabolize it the same as we get older, so thinking about limiting that. And of course, I think it goes without saying these days, but not smoking, and if you do smoke, stop, because it's just not good for your brain. And then lastly, I wanted to mention too, doing the best to optimize your sleep. There have been some studies that about 50% of folks over the age of 65 have some type of sleep problem. Some of them are, diagnosable, that could be treated with your primary care physician or your, treating providers. So really making sure that you're optimizing your sleep. If there is a potential for a sleep disorder, making sure that you're getting treatment for that. Because I think we've all pulled all-nighters in our lifetime, and you're not firing on all cylinders the next day. But if you're kind of chronically getting suboptimal sleep, that's certainly not good for your thinking skills. And lastly, just, thinking about what we call sleep hygiene. So making sure that you have a set sleep time and wake time. Our bodies are really good at making associations, so making sure that your bed, you're not doing, the tablet use or the phone use, bright stimulating things, watching TV, because your brain will start to associate stimulation and brightness with your bed and makes it harder for you to fall asleep. So really trying to foster a healthy sleep environment for yourself is important for your overall functioning, but certainly for your thinking skills as well. And then lastly, I think we kind of already talked a little bit about this, but what we do at WakeMed Neuropsychology, we do provide memory assessments. These in our practice at least, are typically completed in a single appointment. So we have the clinical interview. We do the assessment. We score up your test results, like I said, compare you to your healthy peers, and then provide in-person feedback regarding the results with recommendations. And that is, available with a physician referral if you're interested. So I think that wraps up the presentation portion. Now we're ready for questions.
Let's give her a round of applause.
All right.
Thank you very much.
Yeah.
Thanks for sharing with us. Yeah, let's get into the questions. Just to go over how it works, just to make sure everybody knows. Yeah, you raise your hand at us. I have a microphone. Katie there in the back has a microphone. We'll move the microphones around the room. Please don't ask your question unless you're talking into a microphone. That way everybody in the room can hear, because there are people in the back. I want everybody to be able to hear. And we got a lot of time for questions, and it looks like Katie's got the first one there in the back.
Close. This is a specific question about physical activity. Are there any data for people that are 70 and older that compares people who work all the time, like agrarian work all day long, versus people that go to the gym or just sit at desks, on the size of the brain, the shrinkage issue?
Oh.
So I'm looking to see if staying very active, hard work all your life makes a difference.
I don't know of any studies, but just kind of anecdotally, I have noticed that folks who remain active in work, to some degree, they're keeping their brains active, they're probably being social to some degree in their occupation, that certainly can be beneficial in kind of keeping those connections strong. But I don't know of any particular study that kind of compares that to physical activity. Good question, though. That would be an interesting study. What's that?
You do it as a study.
I should do it? Oh,
I'm sorry.
maybe.
I can't help. I gotta be me.
Red wine's part of a Mediterranean diet, but we also hear about limiting alcohol intake.
Right.
What does the research show with respect to that, and is there a gender difference in terms of?
Oh, yeah. So I know you're right. It is considered part of the diet, and I'm not saying you shouldn't do it at all, but everything, we would consider in moderation. I do know that when we assess alcohol use, typically we think of women, what we consider a normal level of use is different for men and women. And so typically, I'm trying to think off the top of my head and I don't recall, but it would be less, it would take for an average woman less alcohol to become intoxicated or have, those types of effects from alcohol use. But yeah, so moderation, I'm not saying totally stop, but just be mindful of that because there certainly are acute effects of alcohol use on your thinking skills. I think yes, right? So, just being mindful of that you're maybe not metabolizing it the same anymore either. And, when we're speaking about dementia too, there are certain dementias that are associated with alcohol use alone. That's, excessive use, but just being mindful that can have a negative impact on your thinking skills, at least acutely. So, yeah.
So is there some broad curve that you can cite that would characterize how cognitive skills change? So, generally speaking, it peaks at age 20 and then it starts to slowly decline, 5% every decade, and by the time you hit 70, it's all over, or
right,
or something of that sort.
Yeah. Well, there's certainly variability in how that plays out for a lot of reasons we've already discussed, cognitive reserve being one of them, so people certainly can throw off that curve. It depends on what thinking skill we're talking about specifically. So when we talk about like processing speed, for example, that's something that kind of peaks in our mid-30s and can decline after that. Other thinking skills, they can kind of peak in our 60s even and start to decline after that. So it really depends on what specific domain we're talking about. Kind of the difference, again, between those fluid constructs and those crystallized. So there's no one answer for that question, unfortunately.
Over here.
Yeah.
More than once you mentioned auditory functions related to one thing or another. Mm-hmm. Are there any studies that show a correlation between auditory issues such as hearing loss and brain function, brain decline, more atrophy, and in situations where people wait very long to realize there is decline in auditory functioning, mm-hmm. or if they address it early, is there something that shows that the brain is much healthier longer and in relationship to how you address hearing loss?
Not that I'm aware of. I don't know. That's really an interesting question. I think part of it probably would depend on why the hearing loss, or what the actual underlying cause of that is, but I don't know. That's a really interesting question. Yeah, sorry. What's that?
I was just going to follow up on her. If you do not get your hearing checked and you're having hearing loss, people will start making up conversations, and then eventually it does lead to some type of, insanity, and I use that in quotes, but a mental decline due to just being cut off from the world, and they're making up different things.
That's interesting. I haven't heard that. Oh, yeah, sorry.
Hi, could you talk briefly about the latest on medications, as we had no help from them in our family? And
You had no help, is that what you said?
no, they were not tolerated, or there was no effect whatsoever, and that was starting 8 or 9 years ago.
Yeah.
And so I didn't know if there's something new that's out that seems to be more effective in slowing the decline, or
So it seems like they're always, trying to find something new, and the latest that I've heard has not been promising, unfortunately, in that regard. So in terms of medications that are on the market, and I'm certainly not an expert in that, so if you have questions about that, asking an MD might be a good idea. But as far as I know, there are medications on the market more geared toward folks who have mild cognitive impairment or Alzheimer's disease. And about, from what I've read, 50% of people experience some type of efficacy of those medications. It never restores people to where they were prior to the disease, but it can kind of hold them where they're at longer. We think of Alzheimer's disease as kind of like a slow-moving train, and these medications can slow it down even more, but ultimately the end result is the end result, and we can't change that at this time with medications. Does that answer your question? Okay. Yeah.
50% of people 80 and over have cognitive declines, so some of that's due to medication. And I'm from Arizona, which is, we have a lot of older folks there, and most people know somebody who's been killed or seriously injured by someone who is, say, 80 and over, or 75 and over. When I did some research, I did not find any standard testing. Like my dad just had open heart surgery. Is he good enough to go back to drive?
Oh, okay.
And that sort of thing. And yeah. And
when you said killed, but not how they were killed, I was like, what data are you citing?
The car crashes.
I got you now.
There's so many car crashes in Arizona. It's horrible.
Yeah.
But what I'm wondering is anybody working on a test or a series of tests? I don't see anything recommended by the CDC. I see that there's different tests but there's no one recommendation. I mean, when I turn 80, I want to get myself tested to make sure that I can still drive if I live that long.
Right.
Yeah.
Right. Yeah. So unfortunately, I'm not aware of a standard, for folks who have had some type of event like a stroke or something like that, oftentimes they require some type of medical clearance to go back to driving that can be provided by their medical providers. We do a couple tests in our typical battery that are correlated to driving abilities in the literature, but it's not a one-to-one correlation. So if you do well on our test, it does not mean you're safe to drive, and vice versa. There are driving evaluations that you can undergo. There are some private organizations that will do that if you pay out of pocket. I know you can always go and have a driving evaluation at the DMV, but you run the risk of losing your license if you go that route. Yeah. And then there are some occupational therapists who will do like driving simulator type evaluations as well. And I know Duke has a driving school that has a list of resources available online as well. So you're right, there's no standard, but there are resources out there.
Okay.
Yep.
Thank you, by the way.
Sure.
You had mentioned before that some individuals have reserves. Is there a way to build those reserves at our age? Like I'll be 80 next year. Is there a way to build those, and what can we do?
Yeah, so it's always important to keep learning. So like you're doing it right now. Hopefully you're learning something from this talk. So continuing to keep your brain active is really important. And the fact that you're here, probably speaks highly of your reserve anyway, that you're kind of an avid learner. But just doing your best to kind of keep your brain active and engaged. So whether that's like doing crossword puzzles, watching Jeopardy, those types of things, reading, and even some research suggests doing things that kind of involve, remember we talked about physical, mental, and social interaction and engagement. So doing tasks that can kind of check multiple boxes at the same time. There's been studies of ballroom dancing and things like that that certainly can help keep your brain active and kind of keep your cognitive skills sharp. So sometimes I talk about the brain, it's not a muscle, but it's kind of like a muscle. Like if you go to the gym and you're lifting and you're building muscle mass and then you suddenly stop doing that, you start to lose your muscle mass. And some of our thinking skills are that way too. You got to keep flexing them and keep using them to keep them strong. Okay? Yeah.
So I actually have two questions.
Okay.
And since there's a lot of people asking them, I'm going to keep the mic and ask them both.
There you go.
It's a little selfish.
I like your style.
All right. First of all, it's almost inevitable that we talk about these things as normal or abnormal normal cognition, dementia. But I'm wondering if you ever feel like you would be better off, and we would all be better off, if you thought of these more as a continuum, so that we kind of have more normal, less normal, more dementia, less dementia. Are you ever hamstrung in your practice by the binary form of this that this takes?
I think so, but I also, acknowledge that there's kind of some middle ground that diagnoses allow for too, like the mild cognitive impairment would kind of be the less or I forget what your terminology was, but normal, less normal, maybe abnormal. So I think we do allow for that to some degree too. Yeah.
And my other question has to do with whether you'd care to extend just briefly beyond cognitive aging. I'm wondering if you know anything about aging in, let's say, wisdom, or aging in aesthetic sense, emotional sensitivity. How do these parallel cognitive decline, or are they independent of it?
Oh, that's a really interesting question. I don't know. Is that okay? I don't know. But I think that's really interesting, and I want to start looking into that. Does anybody else know anything about that? Looked into that line of research, if it exists? Good question, though. Really interesting. Oh, okay.
So my question was about self-awareness when someone's succumbing from dementia or Alzheimer's. What kinds of conversations in your field have you had about when do people understand that they themselves are beginning to experience that?
So that's really tricky because actually there's a term for that, a lack of awareness into one's deficits. It's a nosognosia, but basically it means you aren't aware of the deficits that you're experiencing, and everyone else is aware of them. And so that can be really challenging, and that's when we kind of utilize family as our ally when we're providing feedback, because they can sometimes speak to, well, I know you're not noticing it, but we're noticing this. And I think it's helpful also for family to understand that it's not like a willful denial of their symptoms, but that a symptom of the disease is that they don't know they have the disease. Because sometimes family will come in and they're very irritated because, well, he just, doesn't know that he can't be driving anymore, and this is such an issue, and it's not that he's denying it willfully, it's that he just doesn't know that he has these difficulties. So it's really challenging finding a balance between providing, that information to the patient and recognizing that they may not fully acknowledge what's going on, but certainly having family buy-in is really important too. I don't know if that answered your question, but.
It's not binary at all. It doesn't happen real quickly. I guess, can you identify any time when people go from understanding to not understanding?
Oh, like for everyone, is it kind of the same? Is that what you mean? Yeah. I'm not sure that I've noticed that it's the same for everybody. Sometimes, someone will have a cognitive profile that is very clear to me. It looks like Alzheimer's disease, and they fully acknowledge it, and it blows me away. Because I'm like, you're not supposed to, acknowledge it. That's inconsistent. So I don't know that it's it's that binary. Yeah. Yeah.
How helpful do you feel it would be to have a baseline assessment before a person is actually experiencing problems? Is that something that would be helpful to you in the diagnosis process?
Yeah, and that actually, I mean, we get quite a few individuals who come in for just kind of a baseline assessment. Maybe they have a history of dementia in their family and they're noticing some of those tip of the tongue instances or some forgetfulness, and their provider isn't super concerned about them at this point, but given their history and what they're noticing, it certainly can be helpful to get a baseline assessment. And for nothing else, no other reason than it would put your mind at ease too, to know that you're kind of within, I don't want to use the word normal, but within the realm of normal, but certainly can be helpful, and we can track that over time. We actually have, tests that we can give that we have alternate forms for, so we can basically repeat the battery but not give you the exact same test again, so there's no carryover. That certainly can be helpful. Not all our tests have multiple forms, but some of them do. Yeah.
I don't know enough about how this is measured or anything like it, but is there any research into the correlation between what you're talking about, cognitive aging, and the plasticity of the brain? I don't know if that can be measured.
Sorry, I can't hear you. Yeah.
Is there a correlation between what's called the plasticity of the brain and cognitive functioning? Can you measure plasticity, and are the two connected in some known way?
Yeah, so he's asking about plasticity, which is kind of like, you can think of the brain's ability to heal itself and to kind of bounce back, and that, as we get older, our brain becomes less plastic, so we're less able to kind of bounce back from things and heal, just kind of like our whole bodies. I mean, this aging process, right? So less plasticity can make it more challenging, certainly, to bounce back from things like brain injuries, strokes, and things like that, which can impact thinking skills. But also over time, it can make it more challenging to compensate for changes, like I showed you, the increase or the enlarged ventricles and atrophy and things like that. Yeah.
Here's one from the front row.
Okay.
I was wondering why it's such a big difference between what I would call short-term memory, like tomorrow I won't be able to tell anybody what your name is, and long-term memory, because I can remember my name of my second grade teacher.
Yeah.
And that's just burned in there somehow.
Right. Yeah. So some of that has to do with kind of that fluid versus crystallized intelligence. So things that are overlearned, seem to kind of be more stable over time, whereas things that are, newer information can decline over time. And just by nature of when you were in, what did you say, second grade? I mean, you probably were able to learn a little faster and recall information, as opposed to, as we get older, like I said, after age 65, that does decline. So there is a difference, and we'll see that a lot. Patients will say, well, my long-term memory is fine, and typically it should be, even in folks who have an abnormal aging process. We would expect long-term memory to kind of hang in there a lot longer than short-term memory. So that's normal. Yeah, yeah.
So I have a question.
Sure.
So do you have any top 5 things that people should be concerned about if they happen? A lot of these things sound like you gradually get worse at this, you get worse at that.
Right.
But is there anything that stands out, like if this happens, you really need to take note of it and go talk to somebody about it?
Well, I would just say, thinking about your daily functional tasks, and if those start to become a lot more challenging for you, like we said, managing medications, managing your finances and paying bills, driving without getting lost or, getting into accidents and things like that. And particularly, I would be concerned about those daily tasks that could have negative repercussions if you're not doing them properly, like managing medications, driving, managing your finances. If you're starting to have difficulty in those areas, that would be highly concerning. Yeah. Yeah. But we also don't want people to kind of wait until it gets to that point either, you know? So if you're having concerns, you know, there's no harm in at least having an evaluation to get a sense of where you're at, from my perspective, but I realize I'm biased, so. Yeah.
There's a test to diagnose Alzheimer's early onset. I don't know the name of it, but I have had friends that were like in their 50s, and I guess it's some type of blood work test.
Like a genetic test.
And whatever was found in the blood, whatever. Like I said, I don't know the name of the test. And how does having a test like that compare to coming to someone like you for your testing and diagnosis, or is there an issue and what is it? Why would you, what would merit doing that blood type test, clinical test, versus having you do your type of testing? And what would lead you to do one or the other? What would be the different circumstances?
Yeah. So she's right. There are some genetic markers that don't diagnose you with Alzheimer's disease, but can tell you if you're at greater risk of developing that. And so I guess that's one difference, is that we, you know, can assist in diagnosis versus just telling someone if they're at risk. I think the other difference would be kind of like what we talked about before. You know, someone could have the same exact or identical looking brain scans, you know, with the atrophy and the enlarged ventricles and all of that. And one person could be demonstrating dementia and the other person might not, for various reasons, including that cognitive reserve that we talked about. So even if you are at risk of Alzheimer's disease, even if they had, you know, a genetic marker that said you will have Alzheimer's disease at this age, it doesn't mean that the disease will be manifesting and negatively impacting your functional abilities at that moment, if that makes sense.
Or if it's a family member, how do you know which route to go? Or if you have a family member, which way should you lead your family member? Because there has to be a pretty hefty cost with each of these types of methods of determining the status of the patient.
Yeah, I mean, I think that would be a really good question for that person's medical provider, because it's hard to say without knowing, you know, details and specifics. But a lot of the genetic testing is done for folks who have a very clear family history of Alzheimer's disease, and typically the hereditary Alzheimer's disease is usually age of onset before age 65. And so without knowing kind of the ins and outs of that, it's hard to answer that question, but I certainly would direct that individual to their medical provider, or even, you know, a neurologist or someone with specialty in that area. But I will say that we accept insurance, so for most individuals, it's not a hefty fee, you know, if they are interested in our testing. Even Medicare? Yep. Any other questions?
So I think I got the last one.
Oh, okay.
But I'm just curious, knowing what all you know and all the information that you provided us tonight, how does that impact how you think about these things, or how you go about your daily life?
You should ask my dad. He's here. How do I think about my parents? That's a really good question. I don't know. Can I say I have to think on that?
Or not about people around you maybe, but about yourself.
About myself. That's a good question. I don't know. I'd have to think on that. Is that an okay answer?
I guess. I said I had the last question. Okay, let me bring you a microphone. Are
you going to like tie it all together here? Oh.
All right.
Oh, okay.
This fabulous person gets the last question.
Well, I don't know if I go that far, but you had talked about, and someone had asked about getting a baseline evaluation.
Yeah.
So my question is, if I refer patients fairly often to this kind of testing.
Uh-huh.
And generally, in order to get the insurance to cover it, I have to provide at least a tentative diagnosis or concerning signs.
Mhm.
So my question is for everyone in here who wants to have a baseline.
Yeah.
How are you finding a problem with insurance coverage if someone doesn't have concerning signs yet and they just wanted to get it, you know, an evaluation?
Yeah, I mean, there has to be some type of, I don't know, maybe Lori can answer this better than I can, but some type of, you know, reason for concern or reason for the testing. And it can be something as simple as, you know, they say they're more forgetful, you know, memory loss. I don't think there's any problem with coverage as long as there's some type of forgetfulness or memory loss or something.
Okay.
And again, that's normal with age, so I think we can all probably say that we have forgetfulness or memory loss.
You, as far as you know, you haven't had someone's insurance like kick it back when they...
Not for memory loss, R41.3. No, that's probably one of the most common that we receive in our practice, so yeah.
Thank you.
Yeah, good question.
Let's give Dr. Kakis one more round of applause. I'll just do the outro from back here. Thanks, everybody, for coming to the Science Cafe tonight. We'll be back here next Thursday at 7 o'clock here in the Daily Planet Cafe. Next week, we're talking about cheese, which might be in the Mediterranean diet. I don't know. But we're going to be talking about cheese and genetics and the microbiome. That's right here. There will be cheese samples. We'll see you next week, everybody. Good night. It's holiday year in review. Yeah, 2019 in science.